So, good afternoon, good evening, good morning to everyone. A warm welcome to this Power Packed session, TRICS 2, your final step towards EDIC Part 2 success. This is brought to you exclusively by 360 Critical Care Online Academy. Myself, Dr. Tapas Kumar Sahu. I am the course director as well as host for this session, and I am delighted to host you today for this interactive webinar with participants joining across the globe. So we are happy to share that the first webinar, part one, which was recall questions analysis of recently completed EDIC part two exam, and that was conducted on 16th June 2025. And I was very happy on that evening that almost 120 trainees and colleagues have joined, and it was very well attended, and we discussed a lot about the current trend of questions and the questions that were asked in the just recently concluded EDIC part 2. So moving ahead, you all, because that was June 16 when we discussed the recall question, and June 17 was the registration date for this upcoming EDIC part 2 session. And many of you could not clear the first hurdle to get a seat in the upcoming part 2 EDIC 2 exam. And but few of you, or I would say most of you today who have joined, they have cleared the first hurdle, that is to get a seat, because it was like immediately filled up. So all the available seats were like completely filled up in, I think, maybe 2 hours or so. So now you are into the final battle, and you should be at this point of time ready with all your strategy, your plans, your the preparation way, how you are going to utilize this upcoming 4 months so that you can finally win the battle. Now we are here to help you, and the first session that we are having today, that would be definitely the game changer in your final EDIC Part 2 exam. So let's dive it without delay, and this is the agenda for today. This is the course faculties, the guest faculty for today, and we'll be discussing unfolding gradually. But the first one is the most important one, and it is now time to hear from someone who is not only walked this path, but a dear mentor as well as a friend, and he has also shaped it for many others. We are honored to have Dr. Adrian Wong, consultant critical care and a renowned EDIC examiner, and also an expert in POCUS as well as research. And he is from King's College Hospital, London. Very happy to have him for today's discussion. And his session will uncover what actually truly matters in the EDIC part 2, beyond just knowledge, and he would be discussing what to expect in your EDIC Part 2, the practical tips and tricks straight from an examiner's lens. So, without further delay, I would request Dr. Adrian to please share from his own
Thank
experience.
you. Thank you, Tapas. It's a pleasure to be here. So, as Tapas said, I'm an EDIC examiner. I've been an EDIC examiner for about coming up to 10 years now. So, what I thought I would do is to just give you some tips, tricks, and some advice in terms of how about to go and prepare and sit your EDIC 2 exam. So, the EDIC, like any intensive care exam, the EDIC exam, any exam tests knowledge. But the Edict 2 tests the application of knowledge. And so whenever I see a candidate struggle, it usually isn't because they don't know something, but rather they struggle to apply what they know and they struggle to put across what they know. It is a clinical exams. You will hear about the various different parts of the exam later on in this course, but broadly speaking, it's divided into the computer-based assessment and the clinical case scenarios. In my opinion, the computer-based scenario for which there is three, so there is the biochemistry section, there is the looped section, and there's the imaging section. That part, I think, tests more knowledge. What does the chest X-ray show? What does the ECG show? Tell me why is the CVP waveform abnormal? How would you look at this biochemistry? What's the diagnosis? So on and so forth. That I think is more knowledge orientated. And my top tip for that one is to read the questions. Don't try to, I I think a lot of the times I'm surprised that colleagues and candidates don't read the question. So once you read the question, obviously the aim is to answer the question. So if the question says, what is the diagnosis? Your answer should be, the diagnosis is this. You do not say, the sodium is low, the white cell is this is this. It isn't that. If the question says, what is the immediate thing that you would do? The immediate thing that you would do is this. Okay. Which leads me to the clinical case scenario, which historically has been the one that more candidates, if you're going to fail one, more candidates fail the clinical case scenarios than the computer-based assessment. The clinical case scenarios are supposed to reflect what happens in a general intensive care unit, not necessarily a specialist intensive care unit, but a general intensive care unit. Having said that, there might be minor questions around ECMO and trauma for the neuro side of things, but they're not super specialist stuff. It's what in the Cobartris competency document. So if you haven't read that, you need to read that. Again, read the questions. Before each of these questions, you are given a bit of time to prepare. So you're allowed to make notes on using your pen, pencil, on a piece of paper, and make notes. The way I would suggest that people approach this first preparation bit is to summarize the case. Either you write down or you highlight what is the most important thing about this case into, say, 4 or 5 sentences. What you don't want to do is to say, well, the platelet count is this, the CRP is this, the white cell is elevated. You probably want to say something like, there is evidence of circulatory shock demonstrated by the low blood pressure, the high lactate, and the poor peripheral perfusion. There is evidence of sepsis, evidenced by the poor perfusion, the raised white cell count, the raised CRP. There is evidence of an acute kidney injury as demonstrated by these things. So with that in mind, what I suggest you do in terms of practice is to go into exam mode. All of you are clinicians. In other words, all of you are seeing patients in your day job and managing patients in your day job. Get into the habit of presenting the patient to your friends, to your colleagues, to your consultants, to even your registrars, your bosses. This is what uh, in getting into the right mindset. So if you imagine you're trying to hand over a case to your colleagues or tell your colleagues about a case, you don't want to say a million different things. You want to summarize the case concisely, highlighting the main points. You, the standard we expect is that of a clinician who is going to look after the intensive care unit for a number of days. We used to say someone who is able to look after the intensive care unit overnight, but actually overnight nothing much happens. So now we say it's for a number of days. If in doubt, ask yourself what you would do on a day-to-day basis. If you were seeing that sort of patient on your intensive care unit, what would you do? Now, the other tip I'm going to give is do not shotgun, machine gun all the options. Get into the habit of organizing your answers and answering them concisely. So, for example, if you are asked what the differential diagnosis are, don't just randomly say sepsis, trauma. bleeding. Have some form of strategy behind that and nuance behind that. In fact, it is actually quite frowned upon if we spot the candidate who does a shotgun machine gun technique to try and answer the questions in the hope that one of the million options that he or she has put out is correct. You will actually be marked, it isn't looked upon favorably in those situations. But generally speaking, for the clinical case scenarios, um, ask yourself what you would do on a day-to-day basis on the intensive care unit. Now, the one big caveat to this is that I don't know where you currently practice, but this is a European exam. So if you practice somewhere where the standard of medicine or the practice of medicine is very, very different, then you need to be aware of that. Having said that, I don't think it's having examined and worked with colleagues from across the world. I don't think it is that different. Okay. Um, so as a safety, as a sort of default position, if you're not quite sure what to do, ask yourself what you would do on a normal basis, and then put that into a very constructive, concise answer. Other things I would recommend, and I see candidates struggle with, um, read the questions. I know it sounds really simple, stupid that I'm emphasizing that much, but you'll be surprised because of stress, because of time pressure, people don't read the questions. Okay. Um, and my final tip, and I'm happy to answer any questions on the chat or anything else about the exam as far as I can give out answers to, is when it is an online exam. It means that you need to make sure that your computer, internet access, etc., are tested. Okay. So, in the history of the exam, I don't think I remember a time where the technical problems was down to the ESICM side. It was always been down to the candidate side. So if you are using your work Wi-Fi or something, make sure you test it at the time that you're going to sit the exam. And what I mean by that is, for example, I know that because of the time difference, it might be just after work hours in India when you sit the exam, where everyone rushes to the internet and watches Netflix or whatever they do. And because of that, there is a surge of demand for Wi-Fi bandwidth. You might want to test what your internet speed and access is during that time. If possible, I always advise colleagues, and being a techno person, to use a wired connection rather than a wireless connection. The last thing you want when you come to an exam is be stressed because your Wi-Fi has broken down, there's connection lag or anything like that. And like I said, the software that we use is capable of detecting where the problem lies. And 99.99% of the time, or at least 100% in my case, the problem always ends up on your side, not the ESICM side. So these little things that you can do to make it easier, less stressful for you, please do that first. And that's it really that I wanted to get across. This is a clinical exam. Ask don't try the machine gun, structure your answers and practice. Probably my top tips to you now. I'm very happy to take questions if there are any, either on the chat or live. But over back to you then, Tapas.
Yeah. Thank you very much, Adrian. This is really helpful, and definitely this has uncovered what truly matters in EDIC Part 2 beyond just the knowledge. And your ideas, your suggestions, your experience definitely matters a lot. Thank you very much. Very well appreciated. And we will be taking the questions in the chat box, if any, and I would be also sharing with Adrian if he needs to step in to clear the doubts. Yeah. So with this, I am moving to the next talk, and this is related to the CCS. And this is CCS means case-based scenarios. And for this, we have a young dynamic, I would say, intensivist come student, come trainee, come now a consultant. Dr. Vijaya Kumar M from Chennai, India, who will take us through the practical CCS examples and explain how to decode them to get the maximum scores. So this is really essential, and I am now handing over and transferring to Dr. Vijaya for his talk. Welcome, Dr. Vijaya.
Thank you, Dr. Tapas, for giving me this opportunity. There are a lot of insights from Dr. Wang. I think all trainees would have taken his insights. Without wasting time, I would start my case. This is like a daily common case scenario, which could may I audible?
Yeah, you are audible. You can just make it in the PowerPoint format. Yeah, perfect.
Yes. As it is discussed, EDIC 2 is really structured case formats. Like you will have a fixed time, and they'll provide you 3 cases. Maybe they'll divide in the each one scenario, maybe 2 questions. As Dr. Wang has mentioned, they'll test your clinical knowledge, communication, decision making. These are the high topics. Mostly they'll focus. The case maybe goes to deep or like how in our ICU it may change, like some pneumonia which progress to ARDS, which further requires ECMO. Like that, they'll frame the questions. You should focus in giving a structured answer approach, like focus on airway, whether it's like breathing, circulation, ABCD format, initial approach. Every examiner will accept the same, expect the this type of answers. You should speak, you should not you should clearly, logical and structured manner you have to speak with the examiner. Like you can mention my initial impression is like this. I would first prioritize this patient for caring of ABC. I will communicate this with my team and start doing actions like that. Every examiner will accept, like especially in critical care, safety of the patient. You should be confident, takes the priority, which step need to be taken first, and you should be safe first, and you should communicate among yourself. They'll see these steps that every examiner expects, especially in critical care exams. Especially in every exam, they'll test you communication skill, like breaking bad news, handling ethical dilemmas, team leadership, especially during crisis. There is a lot of patients comes into your ICU. It requires multiple patients, requires immediate intention. How will you treat? Those things need to be prioritized. And how will you explain to your family? How will you communicate to your colleagues? How will you get the referrals appropriately from the other consultants, especially during uh, especially like patient trashing times? How will you do those things? They'll every examiner try to test you. Stay calm during your examination. Start your think in a structured way. Please avoid silence, especially testing, like appropriately answer. As Dr. Wang has mentioned, don't do mission gun answering. Do for that case, what you need to be like appropriate to that scenario. So you remember some mnemonics before going to exams. Read some guidelines like these things. So without wasting time, we will go to the case scenario, which is a day-to-day real case scenario. This is like a 58 years female, male, recently diagnosed with acute lymphocytic leukemia. Leukemia was underwent induction chemotherapy. Post day 14 of his chemotherapy, he presented to emergency with a temperature of 102, with a 2 days history of temperature, cough expectoration, heart rate was 130, BP was 80/60, respiratory rate is 35. On room air, his saturation was 85, agitated, restless. Initially, you started O2, then you shifted to NAV because of the worsening hypoxia. This is the X-ray. Your first question could be, what is your initial management in a year? This is like a case. They'll give you one case, then you will be questioned in multiple vignettes. This case may progress into different scenarios. First vignette contains 4 to 5 questions. Initial question: how you initially manage this patient? As usual, patient, I would say this patient had a recently underwent chemotherapy, presented to ER with hemodynamic instability and respiratory distress, a little bit agitated. I would start with either HFNC. Then I'll serially observe the patient. If the patient keeps deteriorating, I would go for intubation if necessary. I would assess his oxygenation and respiratory rate frequently. He's in shock with a BP of 80/60. So I would give some fluid bolus cautiously, and if further fluid restriction requests, I would assess his fluid responsiveness either by PLR or other measures. And initially, I would take the patient suspecting sepsis because of post chemo. I would take the blood samples, especially blood cultures, before giving antibiotic. I would ask on ABG, Procal, other sepsis markers, and then I would start my empiric antibiotic as per our hospital policy, and I would monitor other organ dysfunctions. If you mention like if I can find out the source of control, source control, then it could be a bonus points. And if early ICU referral, if patient is immunocompromised, as this patient, and hematologist opinion also I would ask. Then this case, then you will ask about what are your differential diagnosis. This patient might have febrile neutropenia with sepsis, pneumonia, either could be bacterial, fungal, or pneumococcus, pneumocystis carne, and drug-induced pneumonitis, COVID-19, or other viral pneumonitis, or leukemic pulmonary infection, pulmonary embolism, less likely, but possible. Then your question could be how will you investigate this patient? These are the investigations you would order. Then this case has progressed. Then they'll ask you about what are the empirical choice of antibiotics. You would have then you have to give answer like based on our antibiotic microgram and hospital empiric antibiotic policy. Then I would start based on prior hand hospitalization, antibiotic exposure, and maybe beta-lactam and beta-lactamase inhibitor with a combination of macrolide, or if you're suspecting some MSSA without any prior antibiotic exposure, you could give some piperacillin tazobactam. If you're suspecting MRSA, Banco, and viral coverage, fungal coverage if it's not improving, PCP if there is high suspicion. And if you mention about based on cultures, I would modify the antibiotic. Avoid like nephrotoxic drugs like aminoglycosides. This case may go into this patient shifted to ICU. On second day in ICU, the patient was taken X-ray showed the same X-ray. It's progressed to then it looking like ARDS. So what are the definition of ARDS? Then they'll ask, you can answer the definitions. How will you diagnose this patient? What are the differentials for this? Like this, you can give answers. And then this, they may ask you about how do you manage the ARDS in ICU? Low tidal volume, key points. If you give the key point, like main points, you will get priority based marks like low tidal volume, peak titration, prone ventilation if its PO to FiO2 ratio is low, and conservative fluid management, normal neuromuscular blockers, dysynchrony, and early ECMO if its patient is worsening. Then this case may progress to worsening hypoxia. A patient underwent they placed ECMO. What are the indications? They might ask you, what are the indications for ECMO in this case? Contraindications. How will you prognosticate patient if the patient is going to ECMO? And the same case on the day 3, waken up from neuromuscular blockage, but patient is not, you weaned of neuromuscular blockage, but patient not yet weaned, waken up, then you suspected there is some anisocoria, then you did CT, it showed some subdural and subarachnoid hemorrhages. GCS is E2VT, E2VTM1, and then how will you progress? How will you treat this patient on ECMO with bleed, intracerebral bleed? Then you have to give some structured answers like stop anticoagulation. You have to take neuro opinion and neuroprotective measures, and maintain. You should weigh between the circuit clot and you should maintain the you avoid further bleeding expansion. Like this, they may progress. They may take the case into different ways. The patient, this same patient may had a brain death. Then how will you prognosticate the patient? How will you take care of in case organ? If the patient attenders are opted for organ donation, how will you take care of that patient's hemodynamics? Those questions you may encounter. And main thing is family communication. You will definitely get the questions on family communication. I think I will stop here. If any inputs from panelists, I would like to.
Thank you, Dr. Vijay. This was short and crisp, and you have actually explained what it takes to score maximum in the CCS section. So now moving ahead, we have the computer-based scenario after CCS, and for this we have Dr. Alisa Chaudhary from Bhubaneswar, India, and she will walk you through the must-know CBS strategies that you have to answer in your exam to get the maximum marks. And believe me, from our last 3 years or so of teaching people, and so many candidates have cleared, the feedback from our candidates are CBS is really difficult to crack under the stress situation compared to the CCS. And I believe Dr. Alisa would be highlighting what it takes to score the maximum in CBS. Dr. Alisa.
So my slides are visible, sir?
No, not now. Can you share again?
I could not able to stop here my sharing.
Bhagyasri, can you do it? Dr. Vijaya, can you just leave for the time being so that again you re-log in.
Yes.
Stop sharing, you can try, I think.
My cursor is not working.
Okay.
I
Alicia,
have,
can you try share
I,
screen option?
I did. Thanks.
Okay, okay, okay. So in the meantime, welcome Dr. Jitendra from Bangalore. He is also one of our core course faculty.
Hello, sir. Hi, sir. Thank you. Thank you.
Thank you, Dr. Jitendra. Dr. Alisa, you can start now. And I request all the candidates, all the colleagues who have joined, if you have any queries, please continue to post in the chat box. We will be taking the questions in between to save time.
So, very good evening to all of you. Thank you, Tapas sir and Sanand sir. I had actually taken the TRICS 2 course for even the EDIC2 preparation. And actively now I'm involved in the TRICS IDCCM course as a part of the course coordinator and the EDIC1. So first of all of you who have registered, a big congratulations, because that itself I feel is the most difficult job, to sit online for such a long time and keep trying to logging in and then finally register for the exam. So one hurdle gone. The next thing, as I think, Dr. Adrian sir told, that whatever whenever you're trying to attempt any questions in EDIC2, whether CBS or CCS, I think what worked for me the most was, whenever it's something, it's confusing, you're not sure how to get to the correct answer. Try to think that what if this patient was in front of you in your ICU? Then things become more clearer, because they are not going to ask you any rocket science questions. They're going to ask you questions from the cases or the scenarios you deal in your ICU on day-to-day basis. So just think that if you are in the ICU, such a patient comes in front of you, what are you going to do? What's your inherent instinct? What is it going to tell you to do? So that will guide you the most when you are appearing for the exam. Clinical CCS questions, somewhere you get a little more time to think and answer. But when it comes to CBS, which is computer-based scenarios, because the exam was online and they'll show you the case scenarios and photos and everything on a computer. So CBS, probably that's why they've named it. So in that, the time is very limited. So you don't have much time to actually sit and think and answer a lot of things. Stick to the point is the main key, what I will say. Whatever they have asked, stick to the point and answer. Short questions will be asked to you. You should be very precise, no extra mumbling of answers, no extra pointers, because they even don't have time to keep listening to you. They have answers already written down in point basis. The moment you tell the 2 points they want to hear from you, they tick it off and they move on to the next question. And your target should be to answer as many as questions possible in those 3 domains, whichever the 3 subdomains of CBS main domain, right? You should not miss out on any question. If you are taking time, tell them that move on to the next move on to the next question, because you can come back later on to the question. They themselves are going to ask you that, do you want to revisit any question? So don't waste time. Try to appear each and every question, okay? Because everything carries importance and marks. So having said that, they are computer-based scenarios. You have 3 stations, 12 to 13 minutes each, and then the changeover takes around 5 minutes. 8 to 10 questions minimum you are going to have in each domain. At least you need to pass minimum 2 stations for this, for the result to be declared as pass. And it's divided into 3 domains. The first one is your ECG and curves. Second one is radiology or imaging. And the third one is ABG or biochemistry. Okay, very clear cut. You will know the flow and you can attempt easily. If you look at ECG and curves, so you get ECG in that. Mostly they ask you about the MIs, localization, heart blocks, drug toxicities, electrolyte disorders, pacemakers, arrhythmias. And it's never that, diagnose this ECG. After that, there will be a question about what are you going to do about the management of this patient. Similarly, ventilator graphics, they can then go to the next thing is, the ventilator graphics, they can ask you about asynchronies, autopy, CVPs, arterial waveforms, capnographies, ICP curves, IABP, CRRT, ECMO, and TEG and ROTEM. So overall, they concentrate on all this when it comes to the curves part. Okay. The next thing is in imaging. Most commonly, you will get on CT brain, very rarely MRI, CT abdomen, CT chest, and CT neck. Very classic scans, chest X-ray and abdominal X-rays, And then USG, lung and abdomen, you can get, pictures on that, and echo. The third domain will be the biochemistry one, which will be basically trying to discuss about your lab results. So ABG related disorders, electrolyte abnormalities, CSF analysis reports, intoxication, methanol poisoning is what I have heard comes, repeatedly many times. Very classic cases in biochemistry. I found biochemistry really scoring because it's all case based and it's easier to attend sometimes, and the very classical cases. It's not like they're going to give you some sign or symptom which you will find difficult to correlate with the case. Like refeeding syndrome. I myself got tumor lysis syndrome and methanol intoxication. You can have a DK, SIADH. CSW is again one of their favorites. Diabetic insipidus, Addisonian crisis, HLH, obstetric emergencies, and coagulation abnormalities. So these are like few of them what I had got feedback from other people who had wrote exam with me, from my seniors, a collection based on other. This is how I had divided when I had to prepare for CBS. Divide them into 3 domains like this, subtopics, and make sure that I have attempted or covered each of them, at least most of them at least. How do you prepare actually? Definitely a standard textbook you would have read for EDIC part 1, you would have read for your critical care, degree exam. So any standard textbook to refer. Other than that, you have deranged physiologies. You have a lot of OSCE books also. Now, the point of OSCE books is not to mug up questions. The point of OSCE books is you need to time yourselves. Understand when I told you that the time is only going to be 12 to 13 minutes and you have to answer almost 8 to 10 questions. So that should be a habit. Every day from now, try to at least, go for 10 spotters every day. Mark yourself for 10 minutes. Put a timer so that you answer those questions within 10, and then later on you can check right or wrong, go through the explanations. That fast or prompt, that fastness and promptness has to come for you to, approach this question. So that is why you need these OSCE books to practice every day. Okay, put a timer for yourself. For imaging, you have what I had referred was Radiopedia, multiple number of X-rays and scans, like good library they have over there. There's a book of radiology for anesthesia and intensive care medicine, which is a good book, and our good old life in the fast lane. I think that's the most great website we have, which is everything about ECGs, imaging. So a very good source. ECGs, you can go for ECG Made Easy and ECGpedia. For labs, I think data interpretation and critical care medicine was the standard book which you have to solve. It gives you a fairly good amount of idea about how the question can come and how are you supposed to approach. What should be your thought process while answering these questions? So this is the book I mentioned, Data Interpretation in Critical Care Medicine, Radiology for Anesthesia, and ECG Made Easy. These are the, I could not do all of them, but at least the last 2, the OSCE's, objective structured clinical examination, and the OSCE's for intensive care medicine. So I would say these 2 I had done, and actually I used to use a timer and try to attend these questions so that to know how fast I can approach them. The websites which you definitely can, keep it as a handy whenever you want to refer, like in the fast lane. Deranged physiology, I mentioned, ECGpedia. Deranged physiology, the curves are given very nice. CVP, arterial waveforms, IABP, at least for practice to go through to identify easily. Radiopedia, as I mentioned. And if you don't mind spending a little more and getting a crit IQ submission, then that's also good. But I didn't do that. Anyways, we had to spend a lot for the EDIC exam itself. But the most important thing I felt was a good study partner, because studying alone is really difficult for these exams with the kind of commitments we have at work these days, plus obviously, personal commitments. So you need to have a good dedicated study group to help you out, because it's not possible for you to go through all these CBS alone, right? So you can make a group, you can divide topics and discuss among yourselves. So that really helps. Study partner is must actually. This was a just brief overview about what I had gone through or what I felt as a feedback I got from other people to prepare for CBS. Now, if you look at the classic 1-2 cases I have put, so this is like how a classical CBS case in the biochemistry station is going to look like. A 75-year-old female with SAH 10 days later becomes drowsy and polyuric. Usually, they also know that you have to answer 8 questions in 12 minutes. So the abnormal values for at least my session, they had marked with red, And sometimes they even give in the bracket the normal values for you to know it is increased or decreased, because you don't have time. You have to just go through the abnormal values fast and then immediately answer your questions. So here's a female elderly SAH becomes drowsy and polyuric. You look at the sodium, it is low. You look at the osmolarity, it is low. Two things come up to your mind. Is it a cerebral salt wasting? Hyponatremia is definitely there, hypotonic. You want to know it's a cerebral salt wasting syndrome or SIADH. That is the most common thing which you would expect with an SAH. Uric acid looks fairly fine. Urea is slightly elevated. Urine sodium can be elevated in both, so not going to help us a lot. But look at the urea. It is slightly elevated. That means probably a hypovolemic state. Now, SIADH is not hypovolemic. We know it's euvolemic, so we'll go more in favor of cerebral salt wasting syndrome. So the questions they're going to ask is, this is the question put up. They'll ask you, what is your diagnosis? You are going to answer, I think this is cerebral salt wasting syndrome. That's it. No more extra that, okay, the sodium looks low, the osmolarity is low, the creat is fine, the urea looks high. No need to mention all these things. Just one line answer. My diagnosis for this case is cerebral salt wasting syndrome. The next thing is, what will be your management strategy? So two simple lines. I'll go for volume replacement, and I may add a fludrocortisone also for this case. That's all. No need to explain anything because they haven't asked you. There's no time. Just two simple questions. What is your diagnosis and what will be your management strategy? That's all. The next thing would be from an imaging I have put, like, so 21-year-old male with history of fall from height admitted to ER with a GCS of E1, M3, V1. So 5. CT brain has been done, shown below. The CT is done. Your first question just asks you, what are your CT findings? Right? So you have to enumerate all those findings. Okay. We know it's an extradural hemorrhage. It's very classic. It's that biconvex shape. But they have asked you describe your CT findings. So what should be your CT findings? Point number 1, start telling. Looks like a large right-sided biconvex collection. The second thing you can tell, I can notice a midline shift and lateral ventricle compression. Some loss of this thing, gray area, I mean, cerebral edema over here, gray and white area differentiation is lost, and some soft tissue skull swelling. So these 4 points you are going to mention to them. Just simple, crisp points, that's all. No need to explain why this is happening, what is this happening. What will be your 2 most important management strategies? So they've asked you 2 most important. So I would say that, yes, I will go and intubate the patient and initiate on mechanical ventilation. Second thing, I will call for urgent neurosurgical opinion for decompression. So when they ask you to, limit yourself to 2. What is your immediate reaction to this patient? We don't need to enumerate everything because, as again and again, I'll stress on the same thing. Time is the most important when you deal with CBS. You don't have time. Just stick to the questions they have asked. So I've put one question on your, I had put one question on biochemistry and one on imaging. So without dealing much, because there are other sessions, I'll just tell that hard work is noticed and dedication is always rewarded. But for EDIC 2, I feel because there's so much of CCS and CBS, persistence is important, at least for CBS. You need to keep practicing, keep going through, keep timing yourself, keep looking through exercise. Even when you're just simply sitting in the hospital, you're taking a break. There's no harm. Just take out the radiopedia, go through those scans, open derange physiology, go through those waveforms. Keep looking them. Don't try to mug up or get really worried. Just keep looking through those waveforms. See if you got a diagnosis right or not. It's okay, even if it is wrong. You have learned something today. So persistence is going to pay you off for the EDIC 2 preparation. Thank you.
Thank you, Dr. Alisa. And you have narrated it well in almost 10 minutes. There are 2 questions in the chat box. If you or some of our colleagues in the panelist group can take this question.
I'll take the question. How many questions to pass each station? No, I don't know. I'm aware of that. I just know 2 CBS you have to pass. Ideally, the minimum questions is 8. They can go up to 10 questions. That's what they mentioned in the website. 8 to 10 questions for 12 to 13 minutes for each CBS. There's no how many questions. It is 2 CBS you have to pass to be declared as pass.
Yeah, and CCS also you have to pass a minimum 2. So this is really difficult. They can change the passing strategy or passing system. But yes, 70% minimum marks is actually the standard marks for any exam, and they also target in that way. Now the second question is in CCS how they are giving marks. So it is all like if there are 4 suggested answer. So it would be all carrying a single mark. So 1, 1, 1, 1. So 4 marks. So it is not having, previously they were giving 0.5 or the best 5 pointer, 3 pointer, 1 point. But now it is all equal. 1, 1, 1, 1. If it is again 5 suggested answers, so it would be 5-mark question. And finally, they will calculate how many marks you have actually gathered from 4 clinical vignettes or 5 clinical vignettes in a single CCS. Right.
One more query was any other source for data interpretation. So that book, what I mentioned, is very good. And apart from those, those OSCE books also will have a lot of questions on biochemistry and lab results interpretation.
Yeah, perfect. So thank you very much. And now I am sharing with you my part for this session. So just 1 second. I am sharing the screen. So now I would be giving you a snapshot. What were the high yield domains this time in the last conducted EDIC Part 2 exam, and what were the questions that were asked. So we have already taken a recall analysis webinar, so I will not be taking much of your time. But the last exam, just 1 second. Is my screen visible? Okay.
Yes, sir.
Yes, sir.
Okay.
Visible.
So the recommendation for EDIC Part 2 aspirants based on the last in the month of May conducted exam. So they have asked about ECGs, CT scans, ventilator graphics, and ABGs. So there were a lot of questions. Now, the CCS and CBS, they were more focused on the sepsis part, neuro, renal, and post-op patients. You need to now strengthen understanding for the CRRT. Previously, it was not actually asked in the exam, but now they are expecting you to know about how to write, how to prescribe CRRT in your ICU, and what are the troubleshootings normally happen, and what are the complications because of the CRRT. So CRRT is something which has come up in a big way in last 2 to 3 years. Now, stay updated on newer therapies. So this time they asked about CAR T, immunomodulation, and also some of the complications or side effects of the CAR T. Now, soft skills is always a favorite domain in European exam. So ethical dilemmas, family communication, and end of life care decisions. So that has already been discussed by Dr. Wong as well as Vijaya. Now, these are the topics and subtopics that were asked. I have actually taken it from the our recall analysis session, and just to give you in 2 slides. So there were questions from the TBI, traumatic brain injury, cerebral venous thrombosis, intracerebral hemorrhage, brain death, and ICU management. Very standard questions. Neurocritical care, you cannot expect to go to the exam and score marks without knowing these things. And there were questions related to, again, like what would be the decompressive craniotomy idea, or like when you will decide for decompressive craniotomy, how you are going to utilize CT angiogram for brain death declaration, all these things. Now coming to the infectious diseases and sepsis, there were questions related to bacterial meningitis, sepsis with VAB, bloodstream infection, UTI in the CCS section. They have asked about HLH. This is now again, last time also it was asked, and this time recent also they have asked about HLH. Maybe European exam, they normally don't expect you to answer about dengue, but yes, that was asked also this time, dengue. Post of sepsis, listeria meningitis in the bacterial meningitis was the question. And they have also asked about renal replacement therapy alternatives in the dengue SOX syndrome patients. Now, renal and CRRT, I have already mentioned CRRT prescription, citrate toxicity, what are the triggers for the renal replacement therapy, what is the dosing, anticoagulation, and what do you mean by heparin-induced thrombocytopenia, and how you are going to anticoagulate in a patient with heparin-induced thrombocytopenia. Now, the questions again related to CRRT was CVV HDF for a liver transplant patient previously operated. CRRT for lactate clearance was the question. Then how you are going to diagnose citrate toxicity, and how you are again going to diagnose and manage the heparin-induced thrombocytopenia. Now coming to the cardiovascular system, I have already mentioned ECG, advanced ECG. Now they are not asking simple basic ECG. So junctional rhythm plus Canon A waves, bradyarrhythmia plus pacemaker, then different shock phenotypes and how you are going to monitor invisibly. So that was the question related to cardiovascular. And you can see the ECG that was asked in the advanced ECG is AV block plus bivascular block, then left bundle block plus atrial fibrillation management, junctional rhythm with CVP tracing, and again septic shock with cardiogenic shock. So it was a overlap of questions like no shock. Post-transplant and immunotherapy, CAR T complication, cytokine release syndrome that was asked this time also and last time also. So you need to understand now and answer it confidently. Then electrolyte derangements that normally happen in immunotherapy and also hypophosphatemia and HLH confusion, post-CAR T, when you are going to treat in the line of sepsis, what are the sepsis markers that normally you will be getting in the post-CAR T. Now, coming to the hematology and thrombosis, again, very important domain. This time, lot of questions came from the hematology side. DVT plus heparin, then patient is now having thrombocytopenia. Heat, already I discussed. Anticoagulation post-stroke. What would be your the strategy starting anticoagulation? Then cerebral venous thrombosis with bleed. That was the question scenario. Then different graphs of the heparin-induced thrombocytopenia when you are going to start low molecular heparin. Then post atrial fibrillation, stroke, splenic infarct. So pros and cons of going for thrombolysis. Now airway and mechanical ventilation, winning protocol, ventilator associated pneumonia, mini ball indication, bronchospasm happened during transport of any patient, then expiratory hold for autopip, that was one of the graph, ventilator graph they have given. And when you are going to win the patient in CCS, they have asked about how you are going to interpret the increasing PIP. So, and how you are going to find out that yes, this patient is generating increasing PIP. So coming to the surgical critical care, there was the CCS question, clinical vignette 1 on the hepatectomy complications, pseudocyst drainage options in the pancreatitis, post hernia repair, patient had pneumoperitoneum. So that was the question, how you are going to diagnose free air on the X-ray post lab surgery. ROTEM guided transfusion, again very high yield topic. For last 3 sessions in our course, we are getting this as repeated request from the candidates that definitely ROTEM is not being used in most of the centers, but the European exam definitely will be asking you about ROTEM or TEG. So you need to understand the basic questions and they are going to ask you. Ethics and communication, breaking bad news, prognostication, end of life, family discussion. Anyway, in any of the critical care exam, they are going to ask you or they are going to test your understanding. Coming to the toxicology and electrolytes, there was a very typical, I would say, question: hyperkalemia rebound following thiopenton coma. That is people have not answered it so confidently this time. That thiopenton coma, when you are stopping thiopenton, so the hypokalemia would be again going into hyperkalemia. So that is known as rebound hyperkalemia. Hypophosphatemia, calcium disturbances in CRRT. So all these things were asked in the recently conducted EDIC Part 2 exam, and these are I would say in any of the exams in current scenario or time, you need to be very sure about before appearing the exam. I'm not going into all details because that was again one session we have already conducted. Please refer to our last conducted webinar, which is freely available in the YouTube as well as in our website. And with this, I'm stopping my presentation here. And now the next presentation, I would request, just 1 second. So I would request Dr. Abel Karim Elmanoui from Riyadh, Kingdom of Saudi Arabia, and he will be talking about the insight from the recent mock evaluations and how you are going to structure your answers, sequence your answers. Rather, I would say emphasize on the high scoring points in front of the examiner confidently to score maximum. Over to you, Dr. Karim, and thank you for accepting our invitation also.
Hello, Dr. Tabas. Thank you for this opportunity. And I'm happy to share my experience with EDIC exam. I'm clear now or still
Yeah, please continue.
is okay?
Thank you. Yeah.
Okay. So my talk today will try to minimize or telling tips and tricks of how to maximize our marks with structured answers. As I think you know this statement, by failing to prepare, you are preparing to fail. And honestly, you need to prepare well, especially in this exam, because it is a difficult exam. So how do we get success? Simply, we need structure and the system. So to why we need the structure and system, because the exam is need to be confident and need to also be structured way. You don't want to miss any important details, and you will not to hit and you want to hit all the key points quickly and clearly. And the exam is stressful, and the examiner is not just listening to what you know. They are watching how you think, how they want and they want clear relevant structured answers. If you start rambling, you will lose them, you will lose a lot of mark, and you will be confused and lose of a lot of marks. So you need to be structured. You need to guide examiner through your thinking. You come across calm and confident, and that is not just for the exam. And this is exactly what we do in our ICU, real life ICU. You need to make good decision under pressure with patient safety at the center. Your approach equal your success. This is what I want to emphasize about my talk. Yeah. A structured approach doesn't start on exam day. It starts May before and continue even after the exam. So need to go through all. First, pre-exam, you need to prepare yourself. You need not just writing your notes. You need to build your confidence, control your anxiety. Imagine you are yourself in your ICU. You are the expert. You are a decision maker. Be clear and be calm and be professional. Ask for help when you need it. And remember, it is okay to make mistakes. This is the time to make mistakes. No last minute overload. Be smart, be systematic and dynamic. Know your gaps and work on them. Be ready physical and mental and emotional. After that, there is study. You need to put study plan in the corner as the cornerstone in your success. Start early. Start early. Ideally, when you pass part one, you have around from 6 to 8 months to prepare yourself. You need a good preparation and know your exam structure. During this time, this from 6 to 8 months, you need to go through for ESICM Academy. You need to organize your notes from part one, find your people, study groups, mentors, friends who have been through it before, build a plan, write your notes, bullet points, divide topics and highlight important subjects, choose the right sources, practice your approach and answers, understand the exam format. We have 2 days. Day one is CBS and day two CSS, and you need to practice both. you have a lot of source that can help, like some books, as I share some books in the images, some website, it is helpful. Some YouTube channels like 360 Critical Care, it is a lot of helpful free webinars recorded. Also, there's some WhatsApp group, Telegram groups, even AI tools like ChatGPT, DeepSeek. Yes, it is. They will give great for practice. Courses like EDIC 2 preparation course, also it is recommended. Also, TRICS course, I think it is helpful. I recommend it also. I joined mock exam with Dr. Tabas, and it was invaluable, and I recommend it. It gave me a lot of experience, put me stress of exam, and after that they give me feedback and also highlight my strong points and weak points, so I can treat it after that. Now, that is, I think this is the core of my talk, how you study. So for me, it is, must be start focus and preparation of the exam. It must be not start. Don't study hard. You need to start study smart. You can write notes in your books or papers or iPads. Use mnemonics. Use visual aids. Anything to help memory. Study, as I said, hard, not hard, smart, and try to study broad, and don't go deeply. In specific situation, you can go deeply to more information and more study. Then try to write small notes and concise and be clear. And practice with real cases and recall question and old exams. This is the important thing. You need to practice on the old exam and recalls, because it help you how the exam is going, and you can sometimes they are repeating or the concept of the exam, it is repeating, so you be familiar. The exam is split over 2 days, as I said before, CBS, and it include graphs, labs, and radiology. And day 2, it is a clinical case scenario. It is 3 long vignette, or 1 vignette with 4 short cases, or 2 long vignettes and 2 short. Again, your approach is everything. For CBS, we need to practice and know the concept of the question and train yourself on it to get the answer quickly. The time is your enemy. Time flies quickly. You have to manage it well. If you are doing great here, chance of great chances are great to pass. You'll give more confident next day. You need to practice spot and quick specific diagnosis and management, and the practice time management is crucial. You need to practice on approach for the ECG, for radiology, to be specific and be spot the diagnosis immediately. Also, there is some focus images in the exam, so you need to be familiar with this. Also, there is some common graphs you need to practice. Troubleshooting machines like ventilators, CRRT, pacemakers. Learn to spot the diagnosis, at least catch the important clues quickly. make your own algorithm. If that help you, it helps you think clearly. In day two, there is this is CSS, and there is, as I said, the three stations. And during station, they are giving time to prepare. During this time, this time is important to prepare yourself to uh, uh, answer all questions. And I recommend use this eyes approach. Interpretation, you need to highlight clues, red flags, to put differential diagnosis, at least 3 to 4 diagnoses. And first one is the correct answer. Intervention approach, differential diagnosis, right? ABCD approach. And don't say ABCD because they don't like this ABCD. Prioritize your approach, be specific, targeted, concise. In investigation, you need to ask investigation to confirm your diagnosis and help in management. You need to integrate all information and other teams to in your diagnosis and initiation of your plan. And you need to inform your senior and or your consultant, and share other teams to make a multidisciplinary team. And also you need to share with patient if he's alert and he's okay, and also the family, to guide your decision and management. You need inspect and imagine. What mean inspect? Inspect. You need to check response and escalation your intervention or your plan, or escalate, because some patient can put DNR or something like this. And you need during preparation you need to imagine what the examiner will ask you. And if you prepare this, I think you can travel the vignette quickly and easily. There is, I will give some approach, like for polytrauma, you need ABCDE approach, and also some management like specific management and surgical management. This is like a broad approach, and you can put specific trauma in between and with specific treatment or specific intervention. Also for toxicology patient, also you can, it is wide approach, and after that you can concise and be specific for every toxic agent. For also there is ICB approach management. If patient have ICB, high ICB, you need to know how approach this. You need to be systematic and be according the tires. You need to be specific management. Also for our ERDS patient, you have escalation and de-escalations. So you need to know all of them. Also for breaking bad news, you need to be approach and do practice also on this. For EPG also, they are liking this approach. If you can practice, it will be easy for you. Also, this is some slides taken from Dr. Tabas talk before. This is like differential. How can you do approach and differential diagnosis? And you can manage to, during exam, you can easily pick up the diagnosis, and can put many differential diagnoses, and you can manage all. Also, don't forget specific population like obstetric patient and her baby. You need to be check the physiological changes, obstetric related and non-obstetric. Some like sickle cell anemia, G6PD, obese, alcoholic, toxicology, burn trauma, HIV, immune compromised patient, allergic patient for medication or antibiotics, goal of care, comfort and palliative care. Also, early versus late conditions like tracheostomy, CRRT, ventilator. Also controversies like patient have BE and thrombocytopenia, and like this conditions, you need to practice and to be clear decision, and think as you are a decision maker, and you need to ask help for other teams or your senior consultant. After that, after finish this, you need to practice and practice and practice. This is I think this is the core of your success. With small or big groups, you need to practice. You can try some mock exam, as I mentioned before, and create your own mock exam and practice on it. Make target for you and in front of your eyes, and be motivated to complete the road of success. Mistakes equal growth. You will make mistakes along the way. That is okay, and this is the time to make it. Every mistake teaches you something new, and that takes you one step closer to success. After that, you need to approach during exam and time between both days. During exam, you need to read the vignette carefully, read question carefully, look the image and graph carefully. You need to ask to repeat the question if you don't hear it quickly. Don't hear it carefully. Interpret systematically. Use your approach. Try focus in your answer. Be calm. This is some tips during the exam. Answer what asked, nothing extra. Think loudly in structured way. Stay calm. Skip if stuck, return later. And avoid firing random guesses, contradicting yourself, wasting time on tricky, difficult question, changing your answer many times. And after that, after exam, if you follow this approach and prepare yourself well, you will maximize your marks, you reach your goal, and most important, you will be proud of yourself and your perceptions. And if you don't pass, please remember, not passing doesn't mean you failed. You gained experience, you improved, and you will be stronger next time. Once it is over, recall what you were asked, compare with friends and your mentors, evaluate strong and weak points, then rest and relax and share what you learn. It helps others and reinforce your own growth. This is my home message. Organized structure matters. Good preparation equal great success. Your approach is everything. Be clear, specific, hit the target. Answer as you are in your ICU. Practice. Time management is crucial. No loser, you gained. Thank you. I am sorry for this long talk, and I hope for success for all, inshallah.
Thank you, Dr. Karim, for this insightful discussion, and definitely all our candidates and the trainees who have joined this webinar would be benefited, and the success is just waiting for them. So now continuing our webinar, the next talk would be by Dr. Inatullah Said from King Abdul Aziz Medical City, Jeddah, Kingdom of Saudi Arabia, and he will be spotlighting on the common mistakes that candidates do and how to avoid them in the EDIC2 exam. So over to you, Dr. Said.
Thank you, Dr. Tapas. Yeah, so I just have to share it here.
In the meantime, I welcome Dr. Sanant also from Australia, who is the course co-director as well as one of the, I would say, pillar behind success of this course, and he will be sharing his experience and about the course after this talk. So over to you, Dr. Said.
It may
The screen is getting shared or not yet?
No, it has not been shared now. Yeah, it is getting shared now.
Some issue.
Do you want us to share the screen?
Yeah, please.
Okay, just Bhagyasri, can you please share the screen, this presentation?
Just give me 2 minutes.
I can share, don't worry. If there is any problem, just give me 1 second.
Sir, are you sharing?
No, please share if you have. I'm just searching it in my WhatsApp.
Just confirm, sir, if this is the tweet. Sir, is this the correct one?
No, this is not the correct one.
Yes.
The other one. I can share, just wait. Yeah. Is it visible now?
Yes, I can.
Yeah. You can just guide
Thank
me.
you.
Yeah, no problem. You can just guide me when to change. Yeah.
Sure. Thank you, Dr. Bas. Thank you, all of you. I wish you all the best. And so today I will be speaking about the tips and tricks and common mistakes. And next slide, please. Yeah, I think we have discussed very well now what is EDIC part 2 and importance of preparation. So the most important thing, as we all know, that we are all busy physicians, we are having morning shifts, night shifts. So the preparation is very, very important. So many of us take it as easy and, they think it can be done in a month. No, it's not true. And you have to prepare it well. You have to speak to your coordinator who is making rota, and to give you leaves. Especially, you have to take some courses such as TRICS or any other courses, and you need to prepare very well. It's not like it's EDIC is definitely a difficult exam. Preparation is very, very important. So that's very, very important. So preparing for the exam, it takes like 4 to 5 months. And the official and trusted sources as is ASM works and packed modules and courses such as tricks, and a lot of things were spoken about data interpretation in critical care, life in fast lane. So these are the resources we should go through. Okay. So the most important thing is, like, you have to prepare as if you are preparing a real case in your ICU. It's not like, in the final exam, when the question it comes, it's not like a predetermined question, and it's not the question which you have seen before in your critical care practice. It's the same, but the thing is, it's a real case. Here you need to have a systematic, structured approach that will come only with practice, practice, and practice. So I recently shared with one of my group that the Bruce Lee said that I'm not worried from 10,000 kicks, and I'm worried from the one who is practicing one kick 1,000 times. Practice, practice, practice. There is nothing. So what you have to do, you have to have a study buddy. You need to practice with your colleagues. You need to regularly attend courses, and you need to attend mocks and practice. There is no other way, no alternative except to practice, practice, practice. Okay, that. So in the exam, as we know, it's a CBS and CCS, every one of us know. So whenever such a scenario comes, the examiner can give you a scenario like a 25-year-old gentleman presented to ER with acute chest pain after having an episode of fever, and the pain is increasing on lying flat. Or he can give you a scenario that a 50-year-old man missed a session of dialysis and he came to ER with acute chest pain. So anything. So read the scenario very well and read the ECG. You know, whenever you see such ECG, you will think, and a lot of things are going on in your brain. You know, maybe this is STEMI, maybe this is something else. Okay, look at the ECG, read all the leads. It's not like PQRST, what you practice in your MBBS. Here you have to be thorough, like you have to spot diagnose. Your time is very less for you, but you have to have the scenario, fever, miss the session of dialysis, all the leads. There are ST elevations. So this is the case of acute pericarditis. Okay, so causes of pericarditis, he may ask, maybe it is viral, maybe it is autosomal, maybe it's tuberculosis, maybe uremic. So treatment, aspirin, colchicine, dialysis. So you have to have a structured approach for this, okay? So the CT scan of a patient who is intubated in ICU, so they may share you and they will ask you to describe about the findings and immediate management. So here, what you are seeing, systematic approach, if you go by the ABCD here, look at the airway here, in the carina, the endotracheal tube is on the right side, is the right endobronchial intubation. Most likely there is a pneumomediastinum there, there's probably tracheal rupture. On the right side, you find there is a pneumothorax. Okay, then there is a bilateral surgical emphysema, there is atelectasis. So he may ask you, how do you manage this patient? So again, you need to remove the endotracheal tube up, and then thoracic team consult, chest tube insertion, resuscitation of this patient, surgical thoracic team consultation for possible repair. So you need to speak, you need to have an approach. So there are a lot of things you can score in this. Otherwise, you will see just pneumothorax and you will miss right endobronchial intubation, pneumomediastinum, tracheal rupture, surgical emphysema, atelectasis. So you can score around 6 points. So if you just say one, he may ask you what else. What else? Your mind gets blocked. So have a systematic approach, okay? So suddenly a ventilator graph is given and your mind gets blocked. You know, you have seen so many graphs, but the most important thing is in the exam, your mind it gets blocked because you have to practice, then you will go and approach. Look at this. Oh, what's happening here? What is the mode? It is a volume control, tidal volume is 285. Oh, look at the graphs, pressure, volume, flow, volume, all graphs looks abnormal. Pressure graph, there is a dip in the expiration, and flow graph, that the graph is not smoothly touching the baseline. There is a dip and then going up, and the volume graph, there is a dip, and the peak pressures are high, and the scenario may be given, the patient is sedated, RAS is -4, so patient is not improving. So what's happening here? So this, if you read all these things, accumulate, and then actually what it is, a triggered synchrony happening here, which is called reverse triggering or entrainment. Here what you have to do is you have to lessen the sedation, decrease the RAS, and decrease the tidal volume, decrease the respiratory rate. So this is how you have to manage. So you need to know, you have to see these images and you have to practice it, then only you will be able to answer in the exam. Okay. So again, another ventilatory graph, the scenario can be given that the patient is not improving and he's fighting the ventilator, and patient is getting hypoxemic. So what's happening to the patient? So you are left over with only 1 minute. You have to have an approach. So what is written here? Read the ventilator graph. It's written pressure regulated volume control. Here the patient is spontaneously, there are spontaneous efforts. Okay, here look at the flow versus time, the efforts of the patient, and look at the values, numbers. Expiratory tidal volume is low, inspiratory tidal volume is 194, the set tidal volume is 200. Here what is happening is patient is leaking here. There is a volume leak. Actually, this is a real case scenario. Patient had a bronchopleural fistula. So we have to consult the thoracic for the repair. So this is ROTEM nowadays asked frequently in the EDIC exams. So you need to practice a lot of ROTEMs. Sometimes you need to memorize the values. So what's happening here in the exam, everything looks fine. But in time, everything looks abnormal, clotting time, clot formation time, everything gets prolonged, all findings prolonged, which gets corrected in time. So this patient is actually received heparin. You have to reverse it with protamine. Okay. This is a real scenario happened with me a few days ago. I wanted to share this. She is a 35-year-old woman, known case of type 1 diabetic, idiopathic intracranial hypertension, facial acne. She is a smoker, presented to ER with 3-day history of nausea, vomiting, as she skipped her insulin due to poor oral intake. Upon presentation, she was dehydrated. However, she was vitally stable. Sugars were sky high, 25. She was acidotic. Bicarb was 5. Ketones were positive. She was managed with fluids and insulin infusion. However, over the next 24 hours, her iron gap gets closed, but her acidosis did not improve. Her pH remained 7.112. But what are your differentials in this patient? So here you need to read the scenario very well. What's happening in the patient? Idiopathic intracranial hypertension. That means this patient is taking some medication for that. What is that medication? That medication is acetazolamide. This patient is this acetazolamide is causing proximal renal tubular acidosis, non-ANGA metabolic acidosis. So here you have to stop the acetazolamide. You have to consider bicarb infusion. The other differential here is hyperchloremic acidosis. So the examiner wants you how you are approaching this case. So the same question can come in the exam. So you think this is simple diabetic ketoacidosis. So read the scenario, read what's happening to the patient. So have a systematic approach, okay? So you need to ask, our colleagues have shared lots of references are there, X-rays, CT scans, ultrasounds, ECGs, life in the fast lane, go the extra mile, TRICS. So lots of material is available, packed modules. So what you have to do is practice, practice, practice. There is no alternative to practice. Mock exams, don't neglect, don't shy to take the mock exams, commit mistakes, do a lot of wrongs, get feedbacks from your tutors and your teachers, and do the well in the exam and get it through. But if you shy, no, I don't want to take the mock exam, I can give the exam directly, I will pass. No, this is foolish thing. So keep practicing. Have a study buddy, make a WhatsApp group, have a friend, always keep discussing, study daily, be consistent in your preparation. And last minute, open the book, prepare for the exam, you think that you will pass. No, you have to prepare daily. Consistency is very, very important. Okay. Communication is very important. Be clear, be precise. The examiner is actually assessing what is your clinical reasoning, what's your thought process. He's not actually looking at the diagnosis, is how you are approaching the diagnosis, how you are ruling out the differentials, and how you are actually looking the case as real in your ICU. This is how they want to see you. So the chances of passing the exam, if you have this approach, you are very high. Okay. So demonstrate the clinical reasoning to the examiner. And don't keep quiet, okay? So don't rush through the questions, read the question. In this case, as I mentioned, in idiopathic intracranial, so maybe in the exam you may get the medication also, but read the question very well, okay? Don't neglect the preparation, oral and practical preparation, and take good amount of rest at the end. Don't think that you can revise all edict in few hours before the exam. No, take rest, and preparation should be from the beginning, not at the end, okay? And as correctly said, don't ignore the technical requirements, okay? So quick review of your notes, focus on high yield topics, and discuss tricky cases with the peers. There are some cases that are really tricky. In the exam, your mind gets completely blocked. You don't know how to. One of my friend and colleague told me, he said he was unable to reach to the diagnosis. There was lactic acidosis, patient is clinically stable, patient is not hypoperfusing, so mind gets blocked. So you need to have good preparation to get the answer. Practice relaxation techniques, take good amount of rest, trust your preparation. Consistency beats the intensity. Success is where preparation opportunity meets. TRIC course is highly recommended, beneficial in achieving success through well-structured preparation strategy. I wish you all the best.
Thank you, Dr. Said, for this, I would say, very insightful, and you have highlighted the common mistakes that candidates do and how to avoid that. Definitely, your experience would help them. And all of us will agree that we didn't have that type of preparatory courses when we appeared the exam. I appeared in Dublin in 2015 or 14. So it's like nowadays we have so much of resources online available, and so much of like the preparatory courses right now available, and we from like 360 critical care for last 3 years or so are devoted to develop this type of preparatory course, and I'm really happy to have so many mentors across the globe who are sharing their experiences as well as sharing the strategy how you should prepare. So at the end, I would be sharing with you how we are coming up with our tricks to preparatory course, and I'm just sharing my presentation for all of you to go through. Just 1 second. In the meantime, I request Dr. Jitendra to please share his thought process before I just like share my screen.
Thank you, Tapas sir. Good evening, everyone. So it's nice on a busy day. Also, all of you have made yourself free to attend this particular session. So I think we were already 80 plus students were there. So and everybody is told. So be it a faculty, be it the previous students who have attended our course, they have told you what are all the important things you should be looking into. They have shared their experiences. They've shared the questions and what were their mistakes and what they learned from their mistakes have been already shared. So, and most of them have stressed on these particular things, like you should require at least 4 to 4.5 months of preparation. So we are in the right time. So our courses will be starting from next week. So we are right in time. So this is the right time to start preparing for your exams. And we have a WhatsApp group. So you require a study partner. Most of them stressed on that also. So you have like-minded colleagues who are attempting the same exam, who are registered to the course. So they'll also be there for your help. And we as faculty are always available to take up your doubts, to clarify your doubts. And we will be covering most of the topics which have been expected in your exams. So based on every year's question, so we have been changing our course accordingly. So whatever is new is being updated. So we are put our efforts to bring that, I mean, to highlight that, and we know what students usually miss. So that is also being looked into. So all the best for everyone. So do spread the message. So ask everybody to be part of the team. So looking forward to meet you again.
Thank you, Dr. Jitendra. And now at the end, I would be sharing with you what is all about tricks in one page. We know it like we are going to deal an ocean of knowledge, and here you have to be calm, quiet, as mentioned by all our panelists, all our speakers. And panic is not the button to press at this point of time. We have 4 months to go. If it is June 24 today and your exam is on November 25 and 26, if you are planning to appear this November session. And there are some of our colleagues who are planning to appear in the May session. Definitely, they have to start from now. It's not that you will be starting again from January. So the better it would be if you start early. Now you have to organize and structure your approach. Everybody has highlighted this point. There is no doubt that targeted study backed up with a regular assessment. You need to assess yourself. You need to again like analyze where are you now? Is your strategy working or not? Are you improving on your like the clinical assessment, your answering style, time, everything you need to assess. So and also you need to have a real mock type thing where you are simulating the real exam environment. So one-to-one interaction with the experts is also needed. And for all these things we have tried to bring to you this course which would be helpful to you, and this is the structure. So I am now unveiling this tricks to preparatory course for our November session. The course starts on the 1st of July, and we will be sharing our study materials for the first the domain, that is trauma and toxicology, and I would be describing how our course unfolds. So 9th July there would be a mock test. 11th July, there would be a live debrief and everything would be as per the schedule. If there would be any change, we will be having a group, dedicated group, WhatsApp group, and we will be posting all the changes, all the information, all the discussions that we needed among the peers. So everything, there are 11 domains. It starts from trauma and toxicology, cardiothoracic surgery, neurology and neurosurgery, cardiology, sepsis and antimicrobials, respiratory system and mechanical ventilation, oncology, pregnancy, burn and drowning, nephrology and endocrinology, gastroenterology and hepatology, ethics, organ donation, communication, and finally, hemodynamics monitoring, miscellaneous. Don't feel that the course ends here. We have again very, I would say, much appreciated mock exams at the end, as highlighted again by Dr. Saeed, Dr. Kareem, and so many other panelists also, that you need to appear in the mock test, how it feels in front of the real examiner. You are like no in the virtual online format. The examiner is like no looking at you, the questions are being asked to you, and how you are actually answering that in 1 minute or 2 minutes of your like no the allotted time. Now the objective of our course, it is comprehensive. It completes all your syllabus in the upcoming 4 months, and one-to-one interaction is there. This course is not only for EDIC part 2, I would say. If there are certain candidates, certain trainees who want to know how it feels to appear, participate in this type of OSCE based exam, so definitely this would be helpful to you for different country specific exit exams as well. Like in India, there are like the super specialty course like the DM and DRNB, some of the Indian diploma of critical care medicine, some of the international exit exams also, they have also been benefited by like participating, registering in this course, where we like complete from the length to breadth of the critical care in 4 months time. So definitely this course is going to be useful. Now I would be sharing with you the framework of this TRICS. TRICS is targeted review of intensive care syllabus. So once you enroll into our course, we today had like have this Zoom assembly of all the faculties and the candidates. Like we have explained now how the course would flow. Now the date of the course starts, we would be giving access to the TRICS cloud. So this is again a very unique thing. We would be uploading all the articles, the resource materials related to that particular domain. If the first week it is trauma and toxicology, so it would be uploaded to your registered dedicated email account on the first day of July, trauma and toxicology. So you will get all the relevant recent guidelines, some of the review articles. Now you will be starting to like read all these things in the next 3 to 4 days, 5 days. Now on the fifth day, you have to appear the online exam. So that online exam would be in the similar format like the EDIC part 2. So it would be the CCS and CBS. CCS would be 2 CCS and CBS would be around 15 to 20 questions. But these questions would be specifically asked from the trauma and toxicology. The trauma and toxicology questions would be more dealt with, and you are expected to answer these questions in 48 hours time. We have given that time because many of you would be busy in your on-call duties, so it would not be possible to finish this in 3 hours, 6 hours, or a single day. So we have taken feedback from all our previous candidates, and they have all opined that if we'll be getting at least a 48-hour time, so we'll be trying to appear this online through the Google form format. It is not possible to take everyone's exam in the online format one-to-one. So we have created, you have to write the short answers to each of the questions that you are expected to answer in the Viva exam, in the real online format exam. And that would be helpful. And you have to self-assess yourself, because you will be getting all the answers in the real debrief, which would be live, and that live debrief would be preferably on the Friday of every week. So like if you are starting on 1st of July, so the debrief would be as intimated when you will be registering. So there would be a live session where the faculty would be discussing all the answers suggested answers to the CCS and CBS for that particular trauma and toxicology domain, and it would highly rated. It would go almost 3 hours time to discuss in detail. You can like ask the questions to the examiner, the faculty, and they would be happy to answer it back. And it is a very interactive session, I would say. Now, there is a dedicated WhatsApp group which would be created once you register, and there would be discussion among the peers. So you know that yes, there are like 50 candidates, 40 candidates who are trying to get past this real battle which is coming in the November month. Now, this would continue for 1 till 11 number domain, because we have 11 domains modules in the upcoming TRICS 2 course. Now, after this, there would be the mock exams that I have shown to you. Now, this is through online registration, and the team will be connecting to you if you want to register, and we are trying to have a very limited 50 number of candidates in our upcoming preparatory course. And all the things I have already highlighted. The TRICS cloud would be the literature for the pre-reading, the ongoing references. Then there would be like, this would be password protected. And this would be consisting of some of the landmark studies, review articles, recommendations, guidelines. And this online exam format I have already explained. 11 modules consisting of CBS and CCS. Exam preferably starts from Wednesday. Discussion would be preferably on Friday. This would be through like the Zoom assistant. All the the mock exams would be through. The live debrief would be through the Zoom. The meetings would be through the Zoom portal only. And laptop or desktop are the preferred interface for the best experience. Now, I'm not going into detail of the mock exams. The mock exams would be at the end of 11 modules. So be prepared for all these things. If you are really willing to join, so we'll be happy to help you out, and we'll be sharing all the details also in time to come. So this comes to timing for lecture. It would be in the evening time, Indian Standard Time, because this relay would be from India, and there are also faculties from Australia, from UK, and some of the faculties also from UAE, Saudi Arabia. So we would be trying to match to everyone's time, but yes, we have to adjust to the timing. Yeah, all the registration charges and everything will be posted in the group. Don't worry about that. And we will be just after this webinar ends, our team will be posting the flyer for the upcoming preparatory course with all the details, the registration link and everything. And we'll be happy to help you also if there is any doubt. So the questions, in case you have any questions, I would be happy to take. In the meantime, yeah. So everything is actually properly planned. Don't worry. We will be giving also almost 25 days, 20 days for your own preparation after this course ends. So this course starts from July 1. It would be ending towards the end of October month, and your exam is on November 25, 26. So you have almost 20 days for your own final preparation, where you would be going through all the debrief videos of our course. So this videos, the debrief videos, the WhatsApp group will be active till the end of your exam. So don't worry if you sometimes miss the live debrief. So it would be automatically recorded and it would be shared with you in your personal Google Drive. So these are the things which we have taken into account, and we know in your busy schedule, it is not always possible to join live. But believe me, the candidates who join live, so they get the maximum benefit. No, the real, the weekly modules, it will not be possible to take live one-to-one. So the mock exams would be live one-to-one, but the other exams, the module-based exams, the week-based exam, it would be through Google Form. So it would be shared with you the questions, and you would be sharing the written answers in very short format that you want to speak in the real exam, because it will not be humanly possible to take 50 to 70 candidates live one-to-one weekly exam, and it will not be also like possible for you to also be live always in the every week. So we have taken all these permutation combinations in our previous exams, but the candidates feel that it is not possible to get leave as well as time during like their own clinical time, right? So I think we'll be clarifying all the doubts in our the dedicated WhatsApp groups. Anything you want to ask at this point of time, and I request all the faculties also, if they have anything to share at this point of time, please share. And we are dot on time. We started at 7 o'clock Indian time, and we are almost 1 hour 40 minutes, and we will be ending up if there are no more questions. So we'll be posting everything in the group, and this flyer would be unveiled just this webinar ends. Okay, Dr. Ali, don't worry, we'll be helping you out. Okay. Thank you very much. And if there are no more questions, I wish you all the best. And from our team, from all the faculties who have joined despite their busy schedule, I must thank them as well as congratulate them for taking this venture to help the candidates across the globe for clearing this one of the most prestigious exam, European Diploma of Intensive Care. And from 360 Critical Care, we are devoted to renovate, I would say, innovate each time we are coming up with this type of course. Thank you very much. Have safe time and take care.